give us a good line, let the internet be stable, and let this work go on successfully. We ask this in Jesus' name. Amen. I hope you said amen wherever you are. Right. So our first speaker is a lady. She's a senior specialist family physician at the Kolebu Teaching Hospital. She has had 17 years of clinical experience. She's a fellow of the West African College of Physicians under the Faculty of Family Medicine. She holds a Master of Public Health degree. She is also the training coordinator for the Faculty of Family Medicine, West Africa College of Physicians, Ghana chapter. She is actively involved in training at both the undergraduate and postgraduate level, mentoring young professionals with dedication and enthusiasm. She has a keen interest in digital innovation in healthcare, particularly in improving access while maintaining quality and compassion in patient care. Her topic for today is compassionate care in telemedicine, preserving the human touch. So this will help us explore how technology can enhance healthcare without losing the empathy and connection at the heart of medicine. I'm told that she's a very chilling doctor. If you get onto Facebook and you type her name, you'll probably see pictures of different parts of the world. I have personally experienced it, so I can vouch for that. So ladies and gentlemen, let us welcome Dr. Joyce Ono Inoni to give us our first lecture.
Thank you, Prof. And thank you, SoftBank, for the opportunity. Good afternoon to everyone. Our topic for today is compassionate care in telemedicine, preserving the human touch. My agenda for today is to take us through the digital transformation of healthcare. We'll look at the overview of digital health tools, what telemedicine is, the risks with telemedicine. We'll define compassionate care. We'll look at the strategies to preserve empathy in telemedicine. We'll look at a case scenario, the challenges, some solutions, and then we shall conclude. By way of introduction, compassionate care in telemedicine is one of the most important challenges in modern healthcare. 40% of patients say virtual visits feel less personal. What do we think as primary care physicians? Is that true or false? Let us look at the evolution of care from the traditional visits to intelligent patient-centered care. First in the picture, we have in-person care, which most of us are used to and we practice currently. With the in-person care, it's more or less like a face-to-face consult. You can touch your patient, you can perform a physical examination, you have a shared space with the patient, and you can have some incidental moments. For example, you can ask the patient, how was the drive to the hospital? And you can also see their body language. All of this helps you to build relationship and trust. The limitations with this would include long waiting times, which most of us can attest to at our OPDs. We have long distance travel, and then the cost implication. They have to pay for their transportation fare, you have to fuel your vehicle, and others. Next, we have telephone care. This is a voice-only consultation. It is convenient, it improves access, and I think it's familiar to most of us because, like Prof said, most of us have had a telephone consultation at one point in our career to friends, family members, church members, etc. Things we did would include the lack of visual cues, a lack of shared space, and there's no physical touch. The third, which is currently being practiced in some hospitals in Ghana, is telemedicine, which is a video-based care. This is real-time visual consultation with a cropped face or audio only, which improves access and continuity of care. The limitation with this is that there's no physical contact. You are both in separate environments. The patient can be in their office or their home, and you can be in the consulting room. And at times it is perceived as purely a transactional approach towards task completion. AI-assisted virtual care. This is where Ghana's healthcare is moving towards. It involves virtual assistants, algorithms, and models that analyze data. They help to triage patients, support decision-making, and automate some routine tasks. The limitation with this is that it might miss rare conditions. There are issues of privacy, data security concerns, and some regulatory concerns. Let us look at the digital transformation of healthcare. We are witnessing the biggest shift in healthcare delivery since the stethoscope. But with every new tool, we must ask ourselves, are we treating numbers or we are treating people? Healthcare is rapidly adopting digital technologies. This has been driven basically by the occurrence of the pandemic. We all remember that during the COVID era, people still had to access care, and the Zoom platform was used for that. It has also been driven by the need for accessibility to healthcare, especially in remote areas, cost reduction due to the high standards of living, and then high patient demand. And also there's been a shift from episodic care to continuous or ongoing care and remote care. What is the goal of digital transformation of healthcare? The goal is to improve better health outcomes for our patients, to lower costs, and to improve access. Now we should look at some digital health tools. The global prevalence of telemedicine has paved the way for innovative tools that can be tailored to meet the local needs. Most of us are familiar with some of them, like the Zoom and the WhatsApp platform. Some tools are used for consultation, include the video conferencing platform, Zoom, Doxime, Teladoc Health, etc. Others are the secure messaging platforms like the WhatsApp, which most of us are used to, and then patient portals like My Chat and Follow My Health. Other tools include those that are used for remote monitoring, like our smartwatches to check your BP, your heart rates, the home BP cuffs, pulse oximeters, and glucose monitors. We have some tools that are used for diagnostic and clinical support. An example is the POCUS, which means a point of care ultrasound. And I think SoftPOC has championed training in some areas in Ghana. We also have the digital stethoscope, which is just basically like our traditional stethoscope, but this can amplify, it can record, and sometimes analyze body sounds from the heart, the lungs, and the bowel. We also have some data or AI tools, like the AI chatbots. These examples of these are ChatGPT and the Google Gemini, and they can help with symptom triage, they help with documentation, they help with patient education, and then clinical decision support. We have some mental health apps like the CBT apps, which can be used for psychotherapy. Key digital health innovations in Ghana. Ghana is quickly transforming its healthcare sector by adopting digital innovations for remote communities to improve access and efficiency. An example of this is the zipline drone deliveries, which helps to deliver blood, vaccines, and essential medicines to remote areas. We have mobile platforms like the mHealth that helps in the management of NCDs. It also offers education and clinical decision support. We have the mPharma, which helps to manage inventory and reduce drug stockouts. We also have Claimit, which is used for digital health insurance claims. And then we have the SOMAS, which is a public health tool for surveillance for disease outbreaks. And I remember we had the GH COVID-19 tracker app, which was used for home monitoring during the COVID era. Where does telemedicine fit? In 2020, there was a 1,000% increase in telehealth visits in the US. And this is now the standard of care for many chronic and acute conditions. In Ghana, the telemedicine industry presents unique opportunities and challenges that stakeholders need to consider. However, our cultural perceptions of healthcare can affect the adoption rates of telemedicine. Let us define telemedicine. It is real-time remote clinical consultations using audio, video, and digital data. What can telemedicine do? Telemedicine can improve access to healthcare, especially for those in the rural communities and homebound patients. It can reduce the wait time, and it can reduce the burden on physical healthcare facilities. It also decreases the risk of infection because people don't have to crowd in our OPDs, and it helps to lower costs, especially in terms of transportation. Telemedicine risks losing non-verbal cues, the touch, the posture, the eye contact, also human warmth and presence, and then trust, because we know that trust is built through shared physical space. What are the types of telemedicine? We have remote monitoring, which is basically using devices and wearables to track real-time vitals and data remotely. And these are transmitted to healthcare professionals for analysis. We have the real-time interactive services or consultation, which is more or less like the doctor-patient consultation. We have the store and forward, which is a secure way of sending medical images or data to a specialist for review later. How does telemedicine typically work? From this slide, I'm sure we can appreciate the fact that to use telemedicine, the patient and the clinician must be tech savvy to get on the app to book an appointment. At least you should own an Android phone or have a family member that owns one, or have a laptop or a desktop. You must have internet connectivity, and you should be able to download prescriptions to engage in telemedicine. Firstly, the patient must book an appointment online through an app. It needs to connect by video, phone, or chat. The doctor evaluates their symptoms, their concerns, and laboratory results if needed. Prescriptions are given, referrals are offered if necessary, and care plans are issued electronically. Ways telemedicine can support healthcare in Ghana. We can use telemedicine for urgent care in country. It can be used for teleconsultation. It can be used for mental health therapy, behavioral change counseling in patients who indulge in substance abuse. It can be used for chronic disease management and remote monitoring. It can be used for telementoring, which is currently ongoing in some district hospitals, where specialists guide local healthcare providers via remote technology. We can also use telemedicine in Ghana for prescription renewals, for follow-up care, where you check on your patients after a consultation. It can be used for virtual education, giving health information to patients, or conducting training for healthcare providers. It can be used for administrative functions, like online scheduling appointments, and then managing medications to prevent stockouts. Let us look at the balance of care. We need to balance technology and human connection to achieve great outcomes. This picture depicts the fact that on my left, we have technology, which is access and efficiency. And we have on my right, empathy and trust, which is a human connection. Always remember that technology may open the door, but empathy keeps it open. In using technology, we have solved the problems of geography and waiting time, but I think we have introduced a new problem, the risk of efficiency without empathy. What is human touch? What does it mean in telemedicine? It means attunement, and attunement means I see you, I hear you. It means validation. What is validation? Your feelings make sense, understand what you're going through. It means continuity, which means I remember you between visits. What is the core problem with telemedicine? The core problem is the empathy deficit. We should remember that patients don't care how much we know until they know how much we care. And when technology dominates, we have screen-focused care, where clinicians stare at screens instead of the patient. We'll probably end up admiring their home environment, maybe an art craft behind the patient, and not the patient themselves. We tend to have rushed conversations, which are more like a checklist-driven conversations, and the patients feel depersonalized. They feel that their case numbers are not people. Now, to the meat of the day, what is compassionate care in telemedicine? Compassionate care in telemedicine means intentionally delivering healthcare through digital tools while still preserving empathy, trust, respect, and a human connection. We should remember that compassion requires an intentional effort, and it blends our clinical skills with emotional intelligence. As family physicians, this is one of the core principles of our practice, and we must uphold it. What are the components of compassionate care in telemedicine? The first component is virtual presence. What does that mean? It means that during the session, your camera should be at the eye level. You should give undivided attention to the patient, and you should avoid rushing through the consultation. All this helps the patients feel heard. The next on the list is active listening, which involves eye contact. You should maintain eye contact with your patient. You should nod visibly. You should hear both their words and their silence. Affirmation is third on the list. That means validating and paraphrasing the patient's concerns. The next is shared decision-making. The patient is a partner in the care and not a passive recipient. We should have clear and kind communication, which means that you should give the patient a more descriptive and reassuring explanation. We have environmental awareness. That is respect for the patient's environmental context. We know that telemedicine gives us a glimpse into the patient's environment, and we must be sensitive to their environment and their privacy concerns. We also have continuity and follow-up. There should be check-ins after the appointment, and the patient should be sent summaries of the encounter. We have digital aftercare. That means that we can personalize some of the portal message. For example, one sentence about their dog, about their garden, or their grandchild, whichever you saw. What are the key elements of compassionate telemedicine in Ghana? We have multilingual support and cultural sensitivity. Platforms should be designed to communicate in English, Twiga, Hausa, and other local languages, breaking the language barriers and making patients feel respected and understood. We should ask ourselves, do these tools align with our cultural norms, values, and beliefs? Care should be accessible and empathetic for those in the remote areas. We can do that by using mobile phones to connect community health workers with specialists, thus reducing the need for expensive travel. We should also use patient-centered digital tools. The tools, for example, I think that REACH has a tool called the GH Life Doctor app for managing chronic conditions. Why does compassionate care in telemedicine matter? It does because it builds trust, it improves patient satisfaction and medication adherence. It leads to better health outcomes in patients with chronic and mental health diseases, and it reduces the feeling of isolation in vulnerable patients. Strategies, which are practical ways to improve compassionate care in telemedicine. The first strategy is environment. My live audience, can you tell me one key difference you can see from both pictures, the bad setup and the good setup? Something that is striking. The lighting, yes, great. Okay, for clinicians, good lighting is important. The light should face you and not be behind you. The camera should be at the eye level. It should be in a neutral and quiet background. We should remove distractions like our phones, and we should dress professionally. For the patient, you should guide them to sit near a window. They should use headphones if possible, and you should be concerned about privacy. Always ask the patient, are you alone? Do you feel safe to talk? The next strategy is intentional connection. We should always remember that the first 60 seconds of the encounter sets the tone for the entire visit. Before your clinical questions come in, You should greet the patient warmly by their name. For example, hello, Dr. Opoku Asari. I am Dr. Inoni. Thank you for joining me today. Always start the visit with a personal check-in and not symptoms. For example, how has work been? Ask the patient a human question. Dr. Opoku Asari, are you really feeling well today? What has been the hardest part of your week? And then we should always acknowledge the technology medium we are using by saying, I know video visits aren't the same as being in the same room. Thank you for trying this with me. I know this is not the same as being in my office, but I'm fully here with you. This helps to refocus the connection. And you can also offer the patient sometimes hybrid options, which means virtual and in-person when needed. Our third strategy, active listening. We know that on video, small behaviors are magnified. Looking away for 3 seconds feels like 30 seconds of disinterest. So specific techniques and the active listening includes, we should not often and use verbal affirmations like, I hear you, that sounds difficult, tell me more. We should avoid interruptions during the sessions from our phone calls, from people opening the doors, etc. We should restate the patient concerns. For example, you can say that, so what I heard is that you have a headache, and we should avoid typing while the patient speaks or glancing at our phones. The fourth is the use of nonverbal communication. We should always maintain eye contact and lean forward slightly. We should, our tone and pace should be warm. We should have a slow speech because all this convey warmth to the patient. And we should compensate for lack of touch. For example, after breaking bad news to a patient who has hepatoma, you can say, I wish I could put a hand on your shoulder right now. Or you can ask the patient explicitly, how are you feeling emotionally right now? The fifth is using empathy language, supportive phrases. For example, instead of saying your blood sugar is high, say this, I know this number might worry you. Let's talk about it together. You should normalize their struggles. Words like, I feel your pain, I understand what you're going through. And you should invite questions from them. You pause, let them ask questions and clarify their concerns. The sixth is to bridge the gap. You can do that by using guided self-examinations. You gently tell the patients to press maybe their abdomen and tell you what they feel. You can also use a caregiver or a family member's hand if they are present. You should have follow-up check-ins for connection purposes and not for clinical data. You should use visual cues like the doctor is typing because this helps to reduce uncertainty. And the seventh is you should close with compassion. Always remember, the last minute of a visit is as important as the first. Patients remember how you left them feeling. Summarize the encounter to your patient and then check their understanding by telling them to summarize to you what they got from the encounter. And then always express gratitude, thank your patient. Let us look at the scenario. We know that compassion improves adherence and health outcomes in telemedicine scenarios. From the two scenarios, I'm sure that some of us will be guilty with the first approach. But as family physicians, I would want to encourage us to adopt the second scenario. Scenario, a patient with hypertension via telemedicine. Without compassionate approach, the clinician says, your BP is 160/100. Go to the hospital now. The patient feels scared, the patient feels alone. Or he says, hey, this your BP is high. Oh. You are now coming to the hospital. But with a compassionate approach, the clinician says, I can see this number is high. I'm concerned for you and I want to help. Have you had a headache or vision changes? I will stay on this call while we arrange transport. You're doing the right thing by checking in today. Some people were laughing. I'm sure some of us, we do the first approach. What are the challenges with compassionate care in telemedicine? These are design problems we must solve. The first is that you can have connectivity issues or your device access. Internet connection is not so good. Your video is freezing. You have login issues. You don't have suitable devices. All this helps to destroy the flow and trust. And then you have issues with digital literacy, especially for those who are elderly and in the rural areas. They feel disadvantaged or excluded. This may be due to their lack of formal education and other social determinants of health that affects them. We also have issues with time pressure. Teleconsults are sometimes too short. There might be time between 10 to 15 minutes, and they are not suitable for emergencies. You can't have a dire emergency and then you are looking for your laptop or your tablets or trying to get data. You need to attend to that patient. And then there are training gaps. Most clinicians or healthcare providers are never taught digital technology, which is telemedicine or virtual empathy during their medical training. Solutions. We should always have a backup audio. The patient's guides, we can have a pre-call orientation for our patients to guide them through video or text. And then we should block about 2 minutes extra for connection and billing. We should include for training, we should include empathy skills training in our telemedicine CPDs. And for policy advocacy, we can advocate for value-based telemedicine and not volume-based telemedicine. How do we measure compassion? These are some possible metrics we can use to measure compassion. We can use patient surveys, which are post-visit patient surveys. And a sample question can be, on a scale of 1 to 10, how connected did you feel to your clinician during this video visit? We can also use retention to see how the patients are retained and then they return. We can use feedback, qualitative feedback from clients using open-ended comments. And with the clinicians, we can self-reflect using checklists. What's our key takeaway from today? The human touch in telemedicine is a choice. Technology is just a tool and not a replacement for human connection. Compassion can be learned and practiced in telemedicine. Small behaviors matter enormously on video. For example, eye contact, tone, and presence. Patients remember how you made them feel, sometimes more than what you prescribed. Preserving the human touch should be a deliberate skill. And in conclusion, telemedicine is here to stay. And the success depends on human connection. Compassion is the intent behind the click. The winners will not be those with the best technology, but those who use technology to amplify humanity. Every virtual visit is an opportunity to say, I see you, I hear you, and you matter. Thank you very much.
Well, thank you so much, Dr. Inoni, for this beautiful lecture you gave. I like the way your voice remained calm throughout the presentation, even when almost like you were seducing all the audience to get into telemedicine space. I'm sure they will do that. So please write your questions down. We still have a Q&A session on the webinar where we encourage you to put your questions. I've already seen that some of the questions have been placed in the chat box, but we will work with the Q&A space within the webinar. So please put your questions there, and then we will address them when we get to the Q&A session. So we proceed with our second speaker. Our second speaker will talk to us about ethical and legal issues in telemedicine practice. So our second speaker is a distinguished physician, lawyer, and healthcare leader. He's a medical doctor and a barrister at law with extensive experience in both medicine and legal practice. He has served the Ghana Medical Association in several leadership capacities, including chairman of the Junior Doctors Association, Assistant General Secretary, General Secretary, and I think he's also been a Vice President before. As digital health continues to transform healthcare delivery, questions of confidentiality, consent, professional liability, patient safety, and ethical responsibilities have become more important than ever. And we are indeed privileged to have such an experienced voice to guide us through this timely and important topic. So ladies and gentlemen, let us welcome Dr. Med Justice Dufu Yankson, Esquire.
Thank you, Prof, for your kind words. I hope you can hear me. Can you hear me? Fine. Okay. Hello? Okay, so as introduced by hello? So my bit today has to do with the ethical and legal issues in telemedicine practice. This is a lengthy one, but I'll do my best to summarize as much as possible. I might not be able to touch on all areas in terms of individual specifics, but the Q&A session, I'm sure, will also help us through a lot more light. Now, let me say that generally, the conditions under which you operate, i.e., the legal standards, the medical standards, the regulatory standards for in-person care, same is upheld when it comes to telemedicine. So some of the discussions we've had previously under ethics at various levels of our training, you will still find them here. For the part one that deals with ethics, you can see a barrage of some of the ethical principles that we need to go through. I will practically not go so deep into some of them because I'm sure we've all been exposed to some of these as much as possible. But however, as we discuss the details within the telemedicine component of everything we are doing, bear in mind that all these bits are relevant. I'll stress on some as we move along. And there are others that probably I might not go too deep into them. But baseline, all the principles you see listed under the part one of the ethics or the presentation, which is ethics, are all to be upheld and practiced during telemedicine sections. The part two of my presentation will, part two of the presentation will focus more on the legal framework and the related issues that we'll find under telemedicine. Now, baseline for the legal issues beyond the regulatory bits, we have the potential of either being pulled into the civil law components or the criminal law aspects of practice. Now, usually the civil law components will be in the realm of medical negligence or malpractice arising out of whatever we do in the course of telemedicine. And then there are the bits that may be petitions or complaints that will be sent to the regulator, which usually will fall under professional misconduct. And then there are aspects of our practice, whether acts of omissions or commissions, that may amount to crime one way or the other. And those ones will be handled under the criminal laws of the states. So, for example, if in the course of using telemedicine to manage your patients, you perpetrate some fraud in there, then those ones will be handled under the criminal law. And what that means is that you have the potential of going to jail, paying a fine, getting sometimes your license to practice suspended or struck out of the register of practitioners and all of these things. So these are things that we should all be mindful of. Now, like I said earlier, I'm going to just summarize some of the ethical bits so that we can have more time for the telemedicine component. But we are all expected to show professionalism in the course of our practice, whether in patients, in-person care or via telemedicine. But the physician always has a dual role. We are a healer because sometimes the moment the patient talks to you or sees you, they believe that they've been healed. And it's been part of our trade all these years. Of course, we are professionals and we need to be professional. We have a societal contract with them, so we need to. One ethical component or principle we all need to bear in mind is respect for the person or the patient. And under this, autonomy, truth-telling, confidentiality, fidelity, all of these bits will have to be respected whilst you manage patients remotely through telemedicine. Your activities overall, under the utility principle, there should be some balance between benefit and harm. But ultimately, the tilt should be in favor of doing more benefits than causing harm. You need to act with kindness, charity, and all of it. Non-maleficence basically do no harm, refrain from actions that will aggravate a problem or cause other negative results. So as you manage your patients via or remotely, you should understand that all these principles work: justice, fairness, application, and all of it. Consent is one that is very key. In fact, it is one of the principles that breaches of same under telemedicine practice have actually resulted in a lot of litigation. It is one principle that you need to be very mindful of because at all given time, you need to obtain and document proper informed consent when you see patients remotely. Now, informed consent, as we've discussed in the past, is based on a process of communication between the health professional and the patient. It seems to address quite a lot of things: benefits, expected risk, alternatives, capacity or competence, full disclosures, understanding, voluntary authorization. What it means is that after you have engaged a patient in a language that he or she understands, not your Queen's language against his or her local dialect or something. If you need an interpreter, you should bring same into the process. But close of day, the patient should give a voluntary authorization that they understand everything that has been discussed and they are ready to commit themselves. This is just another traditional bit. However, when we get to telemedicine, there will be additions because you realize that within the space would have introduced another component, which is technology or ICT or telecommunication. And there are also issues around it that you have to consider and add to your informed consent arrangement. So it's not just the traditional ones, but the others. We'll speak about them. Informed consent, I think, consent basically will transform some morally forbidden acts or acts that are deemed to be illegal into legally permitted ones. And it's one of the key reasons why we need to get informed consent. Consent is also an ethical and a legal principle. There are laws promulgated by the states that touches on consent. So the 1992 Constitution, for example, our Evidence Decree, the Criminal and Other Offences Act, the Public Health Act, the Patient Charter, and all of these, we talk about consent. The Children's Act still talks about consent for certain bits that will be in the interest of the patient. But under the Children's Act, when we get to telemedicine, you realize that we also need to be very mindful of the provisions of the Children's Act as we see kids or minors or children via the remote arrangement that we use, because we are also supposed to protect their integrity, their privacy, and all of it. So these are things that we should bear in mind. Consent, depending on how you gave it, could be void or voidable. But if consent is given by a child under 12 years, it is completely void. So, for example, if you are doing teleconsulting and you think you have actually gotten proper informed consent from a child under 12 years, the law says that is void. It is not only limited to us. Generally, a child below 12 years cannot even enter into a contract. So we should bear these things in mind. Issues of capacity also come here, whether permanent or temporary incapacitation. So at the time you were examining or you were discussing issues with your client via telemedicine, was he under some sort of temporary incapacitation at the time that he or she gave you the consent? All these things, depending on what is happening, will be subjected to test in the course of any allegations, complaints, or lawsuits against you, and we should bear these things in mind. Whether the person is able to understand the nature and the consequences of the consent that he or she has given, whether it was obtained under duress by you, the practitioner, or some other person who is, in quotes, influencing them unduly. Reasons of fundamental mistake or facts can also be seen, when they occur, are deemed to be void under consent. Now, consent can be express or implied. Express, written, or verbal. But the keynote here is, please, as much as possible, document, because that is what will save you. Anytime you do oral or verbal consent, the implication is that when it matters most, it will be your word against that of the patient. And most likely, the courts will sway towards the side of the patient, simply because the courts are aware that we are supposed to do proper documentation. And I expect that we all will understand these bits and follow them. Sometimes consent can be implied. The patient coming in or dialing through the platform, the ICT platform, to get the video conferencing and all of it done, the care and all of it. There's a certain implication by conduct and also by custom, depending on how things are being done. But in all of it, the ultimate is the written consent. Whether they came in via the implied means or not, please get your informed consent properly documented. Capacity to refuse treatment, all of these things are there. For an adult of full capacity, anytime in the course of your telemedicine presentation, if he feels that he wants to refuse whatever you are doing, they are liberty to do so. And that right sometimes may not be absolute, especially under issues of public health, what have you, like when we had COVID and all of these things. But by and large, a competent adult has the right to refuse medical treatment anytime in the course of care. One of the famous justices of the US Supreme Court, Cardozo J, actually said at a point in Chandler for the Society of New York Hospital, and this was as far back as 1940, litigation amongst us in terms of our practice has been, over 100 years and counting. He said, every human being of adult years and sound mind has a right to determine what shall be done to his body, and a surgeon who performs an operation without his patient consent commits an assault. An assault here is the criminal bit, not the tort one. So this is just to tell you that consent is key, and patients also reserve the right to refuse care. Children, when they want to refuse care, there are some rules that allow us or back us to do certain things. So for example, in our 1992 Constitution, Article 28, it says that no person shall deny a child medical treatment. So this is us, by reason of religious or other beliefs. So if you are doing a telemedicine consult, and just for the purpose of this discussion, this is an academic exercise, let's say a Jehovah's Witness parent is with the child, and in the course of it, we realized that the best for the child, probably after even in-person examination and what have you, even though we may have started with the virtual or remote bit, we'll need to do some blood transfusion. Per this, that father cannot refuse it because we are talking about children here, and the Constitution has given them permanent guarantees. Same as the Children Act. The Children's Act of 1998, Act 560, defines who a child is. And the key principle is what we call the welfare principle. And it says the best interest of the child shall be paramount in any matter concerning a child. And that includes the right to well-being, the right to have adequate health, medical attention, and bits like that. And it actually goes on in Section 8 to say that no person shall deny a child medical treatment just by reason of religion or any other belief. Of course, when you have to do some of these things, there are processes you have to go through. You don't say that there's a certain law that backs you. So if you are even the junior most person in the team, you want to do things on your own. No, you have to route all your challenges through your bosses so that they go through the right processes and we move on. Our physician's oaths that we take, the Geneva Declaration, talks about confidentiality, and it says, I shall hold in confidence all that my patient confides in me. When you are doing telemedicine, whatever comes to you by way of the consultations, please remember that you are under obligation to observe confidentiality. This confidentiality can even be tested under certain situations. Whenever we are dealing with patients, and especially as part of the informed consent seeking process, and then also the ethical principles that will guide us in the course of the care, we should remember that the patients are entitled to full information. So everything about the care, from the doctor's end through the technology end to the patient and the reversals, should all be discussed at length with the patient. So the patient's condition, the management options, the clarifications that they need, the possible risk, identity of the caregiver, any alternative treatment that exists, and what have you. Of course, under emergency situations, there could be some exceptions. Privacy is key during consultations, examinations, treatment, teaching, and other purposes. And for example, in a video setup, when you are dealing with a patient, at your end, how many people may be intruding on the patient's privacy? Some of these consultations may happen in, setups that are in the homes of the patients and what have you, depending on where they are. Who else may be listening? What is happening out there that you may be seeing, and what can you take out and not take out? All of these things are very important, and I'm sure we'll delve a little deeper into some of them. The right to second opinion or a referral is still valid, even though we have, in quotes, moved away from in-person to telemedicine. The right to continuity of care at all times is important. As you manage your patient, you should understand that the patients reserve the rights when it comes to continuity of care. They may need referrals, they may need follow-ups and what have you. So all these bits should be parts of your approach whilst going through the processes with them under the telemedicine arrangement, your personal safety and all of it. So having more or less summarized some of the key or traditional ethical principles, let's look at telemedicine proper and some of the nuances in there. Now, the ethical and legal issues might even arise right from whatever definition you have of telemedicine. Now, there's a simple chart on the screen. For inpatient care, it is the doctor and the patient. It goes just that way. When it comes to telemedicine, the definition shifts away from now, and then there's the inclusion of, in quotes, a mirror or a wedge in the middle. That is the transmission mechanism, the technology. the telecommunication, what have you. So now, in the first bit, in the in-person care, you realize that your problems could arise from the doctor's end or the patient's end in terms of potential suits, complaints, allegations, what have you. Now, when it comes to telemedicine, basically, the definition is the doctor, the telecommunication or the ICT, and the patient. Basically, these are the three bits that are in there. And then care is being routed through ICT remotely to take care of this patient. Now, for telemedicine, the issues, the legalities, the ethics will center around the doctor, it could center around the patient. And then the transmission mechanism, the platform itself will also be the subject of legal issues. So as you deal with your patients, you should realize that they also need to understand what is happening within the ICT direction. In that space, they need to know a lot more. And that is why I was telling that for informed consent for patients generally under the telemedicine arrangement, you go beyond what we discussed under the standard doctor-patient arrangement for the in-person care, and also talk about the potential pitfalls, the failures in technology, the breaches, and all the bits that can happen as part of your discussions with the patients. Now, generally for the principles, when you are looking at ethics within the realm of telemedicine, one of the cardinal rules is that telemedicine consultation must at all times meet the legal, ethical, and professional standard as you have in in-person care. Anything short of this, you are likely going to run into problems. Remember that the duty of care remains same as in in-person consultation. So you just don't act as if because it's a virtual consultation, you are just going to hush over certain things and think you've gone scot-free. Because within the process, you are also supposed to document properly. Sometimes there'll be recordings of the sessions and what have you. So if you don't do things properly and things go south, you realize that there will be enough evidential pieces within the system sometimes to even nail you. That is the more reason why we should not forget some of these. We should also ensure that patient safety, privacy, informed consent, confidentiality are all paramount. Patient safety is key. When you don't have the opportunity to do a physical examination, sometimes if you decide to just proceed and manage the patient based on what you think, you could run into problems. Where your consultation at a point dictates that you end the in-person, the virtual, and then examine the patient in person, you should do that. Failure to do that will actually also give you more issues. One of the key things that we need to do when we are managing patients remotely is to identify the patient properly. Patient identity is key. You could end up dealing with the wrong person. You could end up giving wrong medications. You could end up even prescribing substances that you are not supposed to. And the location of the patient is also key. So confirm identity and location and document same. Location is important because the jurisdiction in which you practice might be different from the jurisdiction where the patient is located. So via telemedicine, I might be seeing somebody in the US, Togo, Nigeria, whatever. The laws of the land, let's say Nigeria, might not permit me as a doctor who is not licensed there to practice. We'll go into a lot more of these things. So it's important you always identify patients and their location because it could be a potential pitfall for you. You also need to ensure that the patients understand the potential limitations when it comes to the technology in use. The traditional principles of medical ethics for in-person care, as I said, are mandatory in telemedicine. So issues relating to patient confidentiality and privacy are key. Now, because of the use of technology, ICT specific, here, there is data involved. a lot of data is being gathered, and you should ensure that there's data integrity and security. If you don't do same, and then you allow unauthorized access to some of the data that you may have collected, especially when we talk about health-related data, then potentially you could have some breaches and that could result in litigation. So it is always better to ensure data security to avoid breaches and then potential litigation. Technology failures and breaches, the privacy, confidentiality concerns, and then at a point you need to let your patient understand the possibility or the need for in-person examination, even though you may have started off remotely. In this whole process, there's what we call the physician autonomy to make decisions that are in the best interest of the patient as well as the professional. Your prescribing policies are very important. You need to explain some of these things to them because here we'll be dealing with e-pharmacies and what have you. Any other treatment option that may be available, you need to explain that to the patient, as all of these are part of the informed consent processing. And then you need to document all verbal, written, approvals as given by the patient. Now, when it comes to the autonomy of the patient, of the physician, your responsibilities as well as your own privacy, you need to ensure that the patient has understood your advice, your treatment or management plan, and the steps for continuity of care. Evidence-based practice is the name of the game now, and you need to observe same. Patient safety, a lot of it relies on your actions or inactions, and you need to ensure that that is achieved because that is one of your responsibilities whilst going through the remote consultations. The quality of care and the positive outcomes that are desired. You need to ensure that the standard of care for protection of patients during inpatient consultations are also applied in telemedicine. Ethics or laws that regulate patient-doctor or doctor-healthcare professional relationships will also have to be observed. Remember that you are not the only person in the chain. There are other health professionals, and you need to ensure that the relationship is kept properly. You need to comply with all the laws that govern medical practice in the specific jurisdiction you are dealing with. I've mentioned earlier the difficulties with cross-jurisdictional practice, the issues relating to licenses, and the possible breaches that you could find yourself in because you may not be registered to practice in that jurisdiction. For example, within United States, the USA itself is a federal state. Each state has its own rules at times, quite different from others. So until you have a multi-licensing regime, you are limited to only one state, even though it is within the same country. Same could happen here. If we have an arrangement where your license limits you to, this is just for discussion's sake, to say Greater Accra, then it means when you are consulting remotely and seeing a patient in, say, the northern region, if you don't have the license to practice there, you may have problems. So it's a jurisdictional thing in terms of state to state. But within some federal states, you realize that the rules are different at some point, and you may need to have, different licenses or registration to do what is there. Whichever specific country you are practicing in, you are required to follow the standard code of conduct for practitioners. Whatever regulations and guidelines that exist, you need to comply. And these are within your control. That is why it's part of your autonomy and your responsibilities. You have to ensure that these things actually happen as a physician. There are also legal and ethical requirements, either by law, as in statute, the regulator. Some are written, some are unwritten. There are some professional rules that we all know might not be written, but same is expected of us, especially under the ethical regime. Then where there are standard guidelines for practice, assuming Ghana today, unfortunately we don't have, but if we had a standard law governing our practice when it comes to telemedicine, you will need to follow all the details in there. Like I said, you need to verify the patient's identity and location. This is your responsibility. Don't leave it to somebody else. And then assess if telemedicine is appropriate for the patient, because depending on what it is, it might not be okay to continue. So in wrapping up with the responsibilities that the practitioner possesses, you may have to convey relevant information to other primary care. And if we are running a proper regime, the lack of these things or your failure to do same will mean that there are gaps within the patient's medical records, and that could also pose problems. The quality of the care and safety of the patients in telemedicine is really important, the data and information, and then you're also reminded to keep accurate and adequate patient records. Now, when no specific laws on telemedicine exist, as we have, doctors will be subjected to the same laws, regulations, guidelines, registration, licensing requirements, or professional standards of conduct and practice as we have in person. Some countries have been able to put up specific laws purposely for telemedicine. We don't have same, but we'll soon discuss those ones as well. You are supposed to do record keeping, you follow up, you do prescriptions and what have you. Now, there may be rules for prescribing certain substances or otherwise, and you need to be mindful of all these things. You should be mindful of referrals. At what point do you refer? At what point do you ask for something else to be done? Can all of these things be done remotely? If there is a need for an in-person examination, you need to, because these are the things that will create problems. We might discuss one or two cases as well. Cross-jurisdictional consultations, I think we have discussed this. And also make sure that you choose the appropriate medium that is suitable for the consultation. There's video, there's, let's say, voice as in mobile and what have you. Remember that if you are talking to a patient via voice, you might not be able to even see some or a lot of the things that the patient will be exhibiting facially and what have you, as compared to, say, a video examination or a visual consult. So at all points, you as the practitioner, you should be able to decide what is best. Now, when it comes to children, just as we discussed within the general principles for care, we always need to protect and safeguard the health and the well-being of children. As per our clinical practice standards, as well as the legal framework, we've spoken about the Children's Act, we've spoken about the 1992 Constitution, but you should always bear this in mind. Consultations will not always be limited to adults. You need to respect the views of the children as well as their parents or guardian, especially the group that we call emancipated minors. And I'm sure you know that group, usually 16 plus. These are people who are not yet 18, not adults per the straight definition legally as our 1992 Constitution has prescribed. But this 16-year-old may be in level 300 or 200 in the university or something. And you cannot say that they cannot be part of any consultation at all in terms of decision making, in terms of consenting and what have you. So you need to make sure you balance all these bits whilst you do your consult. You treat them as individuals and then listen to them properly and give them every bit. Consider their emotional, physical well-being, because kids fundamentally are different from adults, and I'm sure we all know that. So you need to do a lot more for them than probably you may be doing for the adult, but it still represents the same. You need to seek informed consent as we have done, especially if you want to do visual recordings, audio recordings, whether for teaching purposes and other bits, because you know that children are supposed to be protected. And that is why when minors are even involved in crime, generally you don't even publish their faces and what have you. So you need to be mindful of all these things. As I said, there's no specific or single, so we are now looking at the legal framework for telemedicine in Ghana. There's no specific or single statute that has been enacted to date in Ghana that focuses solely on telemedicine. However, we are operating under a regime where the combination of existing laws, regulatory policies, and a national e-health or telemedicine strategy. These are the bits that form the backbone of our legal framework in terms of telemedicine practice. Now, some of the relevant laws within this cohort or combo starts with the 1992 Constitution, which is our mother law, the grand norm, the Health Professionals Regulatory Bodies Act at 857. This is very key for us. This is where the regulators in the health sector are all concentrated. So from our own MDC to Pharmacy Council, nurses and midwifery, psychology, allied health, they are all here. And there are a lot of standards, a lot of legal requirements that are within the various sections for each of the professional groups. Part 1, Part 2, Part 3, Part 4, Part 5 for all the various groups. For us, Part 2 is most important to us as MDC, and it sets out and also regulates standards. It gives the regulator the right to conduct professional, code of conduct for professionals, licensed professionals, and what have you. The Children's Act, as I said, the welfare of children. The Data Protection Act is one of the key or relevant laws under the combo of laws that we are operating at, because the Data Protection Act actually seeks to protect and regulate personal data, including medical records. And we all agree that when it comes to telemedicine, data is key. It also seeks to protect patient confidentiality and then security of data from transmission all the way to storage. The Criminal and Other Offences Act also deals with issues relating to the criminal aspects of the activities that may happen within the telemedicine scope. The HIFRA Act also deals with same. Our own Public Health Act the patient charter, which is part of the Public Health Act, is key, and the other provisions within the Public Health Act that talks about public health emergencies and what have you, and all these ways could fall under the telemedicine arrangement, as we saw during COVID. Then we have the National e-health strategy that we are operating with. So right from the ministry to Ghana Health Service, to the teaching hospital, the districts, even the private arrangements, we have a lot of activities going on, and that's one of the guiding principles for all of us. Now, within the legal framework are potential issues that could come our ways as practitioners. You could be in a situation where suddenly you are liable for certain things. For example, depending on whatever may have happened, a patient could refer you or petition the Medical and Dental Council. You could be referred by a committee of inquiry or a fact-seeking committee. Whether they serve their bounds or not is not the issue. You have been referred there, and you have to go and defend yourself. So potentially, within the legal framework, it throws up a lot of bits that could fall under the MDC in the realm of professional misconduct and the consequences thereof. If you look at the MDC Act, you realize that it talks about issues relating to fines, suspensions of your license, and all kinds of things. So it is not something that we should deal with lightly whilst we are actually in the practice of telemedicine. We know the good that telemedicine brings to all of us, but we should also be mindful of our own practice and the consequences thereon. Medical negligence or malpractice, and these will be cases that will actually go to the courts instead of the regulator. When it goes there, it is you against somebody else. And these are civil matters that will be determined by the courts. If you are not lucky, well, you might be asked to pay some damages and what have you. But beyond that, within the process of trying to defend yourself, sometimes the torture, the medical and emotional, psychological issues that you go through, the, in quotes, money you have to spend, the time lost from practice because you have to be in court and all of it, it is not an easy thing at all. So as much as possible, let's do our best not to fall into that kind of situation. Now, practitioners need to bear all these things in mind. Now, cross-jurisdictional practice and licensing issues with respect to telemedicine, I think we've discussed it. We need to know the rules in the jurisdictions where the scope of practice extends. If your practice goes beyond the borders of Ghana, you should be very clear in your mind that whichever country you are consulting a patient, please, the rules allow you to do same, or you are licensed to practice there, because anything that goes wrong will be held for practicing without license or a license as far as that jurisdiction is concerned. So we need to be very careful. Legalities or challenges around personal data of patients, how you store them, how they are transmitted. The telemedicine platforms themselves will also be the source of your problems. So the legal framework, the Data Protection Act, and all of these things seek to protect and also make some direct prescriptions when it comes to this. For example, the Data Commission, you are required to even have some licensing if you are an entity that stores or deals with data. So this Data Protection Commission may require that transmission platform does certain things. If it is in-house, you might also be required to do same. So remember that there are laws that requires to do certain or a third-party related one. Remember, issues relating to cyber security and disaster recovery can all bring to your doorstep issues of legal challenges. Protection of patients' health data is key. Now, if you fail to obtain proper informed consent, it will become one of the key points or the sore points when it comes to litigation. The breaches we have spoken about, if you decide to leak patients' records, whether it is for personal gain, whether it was for fun, or whether accidentally, you could have consequences come your way, especially when they move to social media. And I'm sure about a year or so ago, something similar happened in this country where a doctor was alleged to have posted something on social media and had to go to MDC. So we should be very mindful of some of these things. You may think that it's a very simple or soft activity that you thought you were doing, but it could come with consequences. So we should be very mindful. The practice standards, we need to adhere to them. If there is non-adherence, it could be the basis for your being cited before the MDC or for some court, proceedings. Professional misconduct, allegations, complaints, you need to do your best to avoid some of these things. Then, of course, the medical negligence itself will come. Now, most times, these telemedicine lawsuits, for example, as we are going to discuss, are things that are evolving. But in jurisdictions like the USA, you can practically say they have crystallized. Even in Ghana, some cases have come up. But in the US, it is a common thing now. But generally, globally, telemedicine lawsuits or lawsuits arising from telemedicine practice are on the rise. And most of them are due to malpractices that arise from fraud, false billing of patients, or false claims, insurance-related business, and what have you. As the scope of telemedicine expands, healthcare financing has always been part of what we do. And here, it is the financing component that people are trying to abuse. Just last month, a company was cited for a $270 million fraud in the US. I think in February, somebody was sentenced for, I think the guy is called Holmes or something, for a $46 million fraud. Of course, together with other people in the chain, and some included doctors. So we need to be very careful when it comes to fraud. And fraud is a criminal activity. Beyond you sometimes having to pay, you could also serve time in jail, and that will also destroy your practice. When you work with third parties, you should be mindful what is happening on those third-party platforms, because that will also be your Waterloo. Diagnostic errors are also one of the common causes of, diagnostic errors, especially when you have deficits in your examination, especially the physical examination. So that in the course of telemedicine, for example, there have been lots of lawsuits that have bordered on things like somebody presents with abdominal pain, and because you didn't have the opportunity to examine the patient properly, you sought to ask certain questions and you think that, oh, this is acid reflux. But meanwhile, it was, say, appendicitis. You let go or you give the patient a prescription, a couple of days later, it's ruptured and all kinds of problems come up. So there are issues in there. You could have a patient who has some stroke or some neurological disorder or a deficit because you never had the opportunity to examine the patient properly. You missed it, or the diagnosis was delayed, and all of these bits could actually have problems. There could be some rash or some lesion on a patient. Maybe it's cancerous or a life-threatening activity, infection or anything. But because you never had the opportunity to look at these things properly, you ended up missing the diagnosis. And all these bits have come up to haunt us as doctors who were using telemedicine. And then breaches in the area of the data, the privacy, the confidentiality, the cross-jurisdictional practice license issues, where you have failed to perform in-person examination. You should always bear this in mind that irrespective of whatever you are doing, if at a point you believe that you need an in-person examination, please let the patient understand and either refer the patient or if it's possible for the patient to come to you, please do same and get them examined properly. We need to adhere to the practice standards. Non-adherence will put us into trouble. Now, when it comes to telemedicine prescriptions, there are a lot of fraudulent schemes and there are kickbacks that also happen in there. And all of this could set you up for a potential criminal trial. What it is that some of the companies, some of the owners of the platforms are actually in cahoots with some doctors. They put up certain claims that are not stricto sensu part of the activities or the management of the patient. They prescribe certain medications, what have you, and they themselves have other companies that are supposedly supplying some of the products. And you as a doctor, you might not even be aware, or you might be aware because sometimes you also fill and sign certain prescriptions for them. So you should be very careful when you are dealing with telemedicine prescription. It is one of the areas that for now in the legal realm has become a fraudulent conduit for people to make a lot of money from the system, from insurance companies and what have you, where there are documentation failures or gaps. It is important. Documentation is important because evidential value of medical records is really important. It is a real deal. As we say, the name of the game is documented evidence. So please make sure you put a lot in there. Now, on this pharmacy bit, it had become such a big deal. One online, pharmacies came up, such that in the US, the year 2008, the Reinhart Act was actually passed to regulate online pharmacies. Without in-person examination under this act, you cannot prescribe certain controlled substances, say opioids, stimulants, and others. So these are things that we should be mindful of. In Ghana, the Pharmacy Council regulates online pharmacies and prescriptions. There's something we call statute of limitation when it comes to medical malpractice. Generally, the statute of limitations generally is about 6 years for a lot of activities in Ghana. But when it comes to medical malpractice, as we see in the Medical and Dental Council Act, the Part 2 of the Health Professional Regulatory Bodies Act, you have a 3-year window within which to bring medical malpractice suit. This may be good for us, this might not be good, because if it comes after the 3 years, you are likely to have a defense that, look, they are statute bad, but usually this is what it is. And in the US, states like Pennsylvania have that of a limitation of 2 years. And within that period, a lot can happen. How to prevent these legal issues? Adhere to established standards or guidelines, obtain right information, ensure data security and protection, data encryption, what have you, obtain valid regulatory license. Patient safety is paramount. Remember that. Doctor or provider responsibility, liability, and accountability exist, and you need to ensure you avoid any pitfalls. Legal and ethical protection for patients exists, and they should be adhered to, and same should be safeguarded. The standard of care in in-person care is same as in telemedicine. You remember, we always need confidentiality, data security, and privacy. Act with same professionalism as you always do, and then make sure your licenses are valid. Observe patients' rights, as we know under the patient charter. Verify patients' identity and location, ensure proper documentation, obtain informed consent, and remember to do in-person care or referral if need be. Remember, virtual care demands or requires real accountability. So always bear in mind that when you do teleconsulting or where you practice telemedicine, there's always accountability as well. Thank you very much.
Thank you very much, Dr. Justice Youngson. This has been a mouthful. We've covered several aspects of the telemedicine, and he tried to relate it to regular practice when we are doing our regular practice, the things that we do that we should extend into telemedicine. We have one more presentation from our sponsor, AstraZeneca, one of the world's leading biopharmaceutical companies. We have their rep here, Farm Dr. Ellen Domeku. She's going to give us something. She'll tell us something. So, ladies and gentlemen, let's listen to Dr. Ellen Domeku.
Thank you very much, Dr. Inoni and Dr. Yangsen, for the insightful presentation. In fact, discussions like these remind us that medicine is always advancing, and as evidence increases, it's important that we advance to incorporate the evidence into our practice. And today we'll be looking at one of the areas that medicine has advanced. Initially, we used to look at type 2 diabetes as like glucose disorder. But right now, we are beginning to look at it as a progressive cardiorenal disorder. So when we are treating our patients too, we have to have it in mind that it's not only about their glucose, but also about their kidneys and their hearts. As we all know, and as observed in most of our patients, type 2 diabetes initiates a silent cascade of heart and kidney damage. Because the heart and kidneys do not operate in isolation, a damage in one would more often than not lead to a damage in the other. So when we are treating our patients, we have to have it in mind, not just are the sugars controlled, but also long-term, is my patient's kidneys and their hearts going to be fine? As such, we have to make sure that we are incorporating early interventions that are also guideline recommended to break the chain of progression to cardiorenal complications in our patients. And one medication that has proven to do this very well is Forxiga. Forxiga addresses overlapping pathways in diabetes, heart failure, and kidney disease. So when it comes to type 2 diabetes, Forxiga is indicated in adults with insufficiently controlled diabetes mellitus. And also, right now, it is indicated as monotherapy in combination with metformin, or even as a standalone drug when metformin is not indicated in a patient. And it is shown that it is going to reduce the risk of hospitalization for heart failure or reduce the risk of progression to nephropathy for your patient. And when it comes to CKD2, Forxiga is now part of the standard of care for patients with CKD, with or without type 2 diabetes. And in heart failure too, Forxiga is known to be used in managing symptomatic chronic heart failure in patients with or without type 2 diabetes. And we will find out later in the presentation that Forxiga can be used for preserved or reduced ejection fraction heart failure. When it comes to type 2 diabetes, because we are worrying about the kidneys of our patients, we would want something that has evidence backing it that it can reduce progression to nephropathy. And Forxiga has shown that through several trials, one being the DECLARE-TIMI trial. So in the DECLARE-TIMI trial, over 17,000 patients with type 2 diabetes, some with established cardiovascular complications and some with multiple risk factors, were randomly made to receive Forxiga or placebo on top of standard of care. And what was observed was that Forxiga reduced the progression to nephropathy by 47%. So when you know that a patient with diabetes has risk of renal complications and there is a medication that is going to reduce this risk by 47%, then the question is, why wouldn't you initiate the medication for your patient if the patient is indicated? In type 2 diabetes, traditionally, most commonly, we will see DPP-4 inhibitors. However, what Forxiga have on top of lowering our glucose is that it is also going to give the patient renal benefits, as we've said already. And also in our type 2 diabetes population, most commonly, they'll present with overweight. And Forxiga is known to provide a moderate weight loss benefit for these patients, something that I'm sure most of our patients would desire. Now, knowing this, I'm sure that when we are looking at our type 2 diabetes patients, especially those coming in with multiple risk factors, those coming in, they smoke, they have family relations that has already had a cardiovascular event, or they have hypertension, we undoubtedly want to put them on a medication that is going to reduce their risk of progression to chronic kidney disease or heart failure. And one such medication is Forxiga. As stated earlier, Forxiga is not only used in diabetes, but it is also a standard treatment in CKD. Over the years, one medication that has been used for CKD is the RAS inhibitors, and they've been working. However, what has been observed is that many patients continue to have residual cardiovascular risk. So it is estimated that more than 40% of patients on RAS therapy alone may develop a renal event. So that tells us that there is still more we can do for our patients. And as a matter of fact, as the renal event persists, their cardiovascular outcomes too worsens. So if there is more we can do for our patients, and as such therapies exist, so why wouldn't we put them on our patients? One may ask, so why are SGLT2 inhibitors, that's the class Forxiga belongs to, why are they different from the RAS inhibitors, or how do they act? So briefly, they block the SGLT2 in the proximal tubule. As such, more sodium and glucose is going to restore tubuloglomerular feedback. We know that if the feedback is disoriented, the kidneys are not able to work as they should, and then the renal function is going to progressively decline. But if we have the medication that is going to restore this feedback in the kidneys, then it's going to help slow down the decline of renal diseases. This medication is not just methodological alone or the mechanism alone, but it has also been accepted by a lot of guidelines across the world. So the KDIGO guideline now recommends that SGLT2 inhibitors like Forxiga be used as first line for CKD, regardless of type 2 diabetes status. Also, American Diabetes Association also recommends this as first line for patients with CKD and type 2 diabetes. So when it comes to your patients with type 2 diabetes CKD, it is almost like a non-negotiable for them unless the EGFR is not permitting you. And when it comes to your patients with CKD alone, you know that because the RAS inhibition alone would not do the work, you have to add Forxiga to it so that it will slow the decline of their renal function. In fact, it is a class 1A recommendation when it comes to treatment of CKD in patients with an EGFR of less than 20. Now, there have been several clinical trials backing Forxiga's use in CKD in both type 2 diabetes and patients without type 2 diabetes. And one of these trials is the DAPA CKD trial, a landmark trial. And in this trial, over 4,000 patients, some with type 2 diabetes and some without type 2 diabetes, were randomized to receive Forxiga or placebo on top of standard therapy. And it was observed that Foxzilla was able to reduce the progression to renal outcomes. And these renal outcomes stated were declining kidney function, developing of end-stage kidney disease, or renal or cardiovascular death. And Foxzilla was able to reduce that risk by 39%, something that is very significant. And this happened whether the patient had type 2 diabetes or the patient doesn't have type 2 diabetes as seen. So the earlier limitation or the earlier notion that SGLT2 inhibitors are only for patients with type 2 diabetes has been debunked. Also, while we are initiating the medication for our patients, one thing that is very common in practice is the inertia to initiate the medication very early. Sometimes when the patient comes, we are a bit reluctant. We think that the patients, they are doing well, so why should I add more to the patient? Of course, we are thinking about polypharmacy and the others. But one thing we have to make sure, or we have to have in mind, is that when it comes to conditions that are progressive, early initiation is key. So when it comes to initiation of Foxzilla, it was observed that people who had it initiated at an eGFR of 75 ml delayed their progression to dialysis by 15 years. I'm sure as clinicians, we appreciate how much 15 years is for our patients. And so if we have a medication that is going to delay progression to dialysis, especially considering our setting where dialysis is quite expensive for a lot of patients and not readily available, then this medication is something that we shouldn't hesitate to initiate for our patients. Now, another key place that Foxzilla shines is heart failure. And for me, the most interesting thing when it comes to heart failure is that it is able to reduce the risk of cardiovascular death and worsening heart failure, both in patients with reduced ejection fraction and preserved ejection fraction. So in heart failure too, clinical trials have been done to show that Foxzilla is actually able to reduce the risk of hospitalization as a reason of heart failure and reduce cardiovascular death. And this is in both heart failure with reduced ejection fraction and preserved ejection fraction. What this means is that sometimes when patient comes, especially when we are in resource limited environments, sometimes we are wondering, heart failure, query preserved or reduced. Sometimes if we are not able to make that query early, it means we will delay therapy for the patient. And we know that delaying therapy too is going against the patient. But if you look right now, comparing the therapies used in heart failure, you can see that when it comes to dapagliflozin, that's the molecule of Foxzilla, it shows consistency with no attenuation across the ejection fraction continuum. So meaning, regardless of the ejection fraction, whether it is preserved or reduced, the benefit still remains intact. So you are not going to worry about what if my patient is preserved and I'm putting the patient on the medication and the medication is not going to give the patient the benefits. So if we are living here with forgetting anything at all, I want us to remember that when we are looking at our patients, we should look at them, not just the symptoms they are presenting with, but also long-term, and put them on Foxzilla because it is going to slow down cardiorenal complications. And it is 10 milligram once daily, with or without food, at any time of the day. Thank you.
Thank you, Ellen. So Ellen says Foxzilla all the way.
Exactly.
Heart failure with reduced ejection fraction, preserved ejection fraction, diabetic without nephropathy, with nephropathy, all of them, give them Foxzilla. Well, I shouldn't tell you the cost yet. That's the smart part. So, ladies and gentlemen, we are now at the Q&A section. We have quite a lot of questions for Lawyer Yankson. But I'll start with one in the chat for Joyce. Is that the speaker said we shouldn't type when patient is talking. When and how do you document what the patient is saying. So that's for Joyce, if you can comment on that very quickly.
All right, thank you for the question. I think there are two ways you can document when you have an encounter. One will be real time. When the patient is speaking, you should wait for the patient to finish speaking before you document. You can't be typing when the patient is talking to you. You must pay attention and listen actively, like I said, and then you document. Or you can do that quickly immediately after your consultation with the patient.
All right, thank you very much. So we'll go to the Q&A now. So the first one says, with respect to confidentiality, a patient, adult, counts for care, but the bills are taken care of by a third person. The third person claims he or she wants to know what she's paying for. The patient doesn't want that. The third person either says, either I know or I walk away, indirectly forcing the patient. What do you do?
Okay, so here the first thing is what type of patient? Adults?
Adult.
Okay, so if it's an adult, the truth is that we have a responsibility towards the patient. That is our first line of responsibility. Yes, whoever is helping the patient finance the cost of healthcare is relevant in the course of, our activities. But once our patient insists that we shouldn't make certain disclosures, unfortunately, we'll have to be bound by his wishes, especially if that patient is an adult and of sound mind. If the patient is not of sound mind, that becomes a different thing altogether. But until we get a consent of the patient to release details of his or her health records to that third party, we'll be in the wrong if we decide to go ahead because the person says, if you don't tell me, I won't pay. When the patient is saying, please keep this. Now, there is also another version. When it comes to certain conditions, for example, HIV, and then let's say, just for discussion's sake, a husband and a wife. The husband is the one paying the bills. The wife, for now, is the one who is infected. There's also a second line responsibility on us. We need to ensure that in the interest of public health and the safety of the husband, this husband, however, the first line of discussion is between us and the patient to ensure that she agrees, and then we cancel. I mean, we would have done the counseling and all those bits, and then we find a good way of, informing the husband, and then we also go through those other processes. If the wife insists that we should not disclose her status, forget about this health financing component. Under the current rules, the AIDS Commission's rules are such that we will have to let the husband know. Those bits are for the purposes of the family relationship that they have and the risk that the husband ultimately will also carry. We want to reduce the numbers of, HIV positive patients we have in the country. So those exceptions exist, but even that, we will need to let our clients know that this is the situation. And then it is the law that is empowering us to go ahead to do those disclosures for the sake of the family and everybody. Otherwise, like I said earlier, we cannot go against the words or the wishes of the patient.
All right. So that's the guiding principle. Before we will go to Ellen now, some people want to know whether you are a farm doctor or regular doctor. So let me answer that. You are a farm doctor. So there are a couple of things for you. The first one is, what is the cutoff EGFR to initiate or continue Forxiga? And then what is the cost effectiveness of Forxiga as it pertains to the average earning Ghanaian? Okay. That's this. So what? I'll read them. No, for example, we should make it short.
Okay. So for the EGFR cutoff for initiation of Forxiga, you can initiate when the EGFR is greater than 25. However, if you've already initiated, you can continue till dialysis.
Okay. And then cost effectiveness.
So
for
it's
the
very,
average Ghanaian.
it's very cost effective.
Okay.
Considering that your patient is facing dialysis or heart failure, it is very cost effective for the average Ghanaian.
Right.
It is very common on our market, and I'm sure you probably have prescribed some for your patients before.
Why are you looking at Dr. Yankson? Why are you looking at Dr. Yankson? All right, okay. There's an interesting one here. I have a patient who resides in Ghana where I provide care. He has had to travel to the US. Will follow-up care via telemedicine constitute a jurisdictional breach?
Well, yes and no. Yes, in the sense that it depends on the status of this particular person who is now in the US.
Mhm.
It also depends on what kind of care you are taking the patient through. And it also depends on exactly what was happening at the time, the sort of advice or direction you give, and the potential consequences. But the ideal thing is that you should be very mindful. In fact, I remember at a point I had to give some advice to some family or relatives, extended to who are in the US. After listening to them and their complaints and all of it, having gone to see some doctors and all of it, I made a diagnosis. I told them what was happening. However, I typed everything and said, the next day or two, make sure you get to your regular doctor. Tell him that this is a summary that your nephew has given you. He should also have a conversation. And if he thinks he wants to have any discussions with me, he should.
Available.
Yes. So you need to be very careful the sort of advice. If it's something like a first aid and those basic things, maybe it may pass. But if it's active care where they are paying and all of it, then potentially, if things go wrong, you could also be cited for whatever. Because in the US, there are doctors who you can actually teleconsult.
Mhm.
And if things go wrong, they'll be held responsible. So if they are there and you choose to continue to treat them and things should go wrong, and they decide to take action based on US law, you will find yourself in trouble.
So I'll read the next three and then both of you make short comments. Since NHIA and HEFRA accreditations are facility specific and location is key in the practice of telemedicine, what happens if I practice telemedicine at home? The next one says, what are some of the responsibilities of the client in telemedicine when it comes to privacy and confidentiality? Also, can the clinician take a client on for leaking personal details to third parties, e.g., clinician's name, address, phone number, signature, stamp details, etc. The other one says, to facilitate teleconsultation, can't we use secure software to record and transcribe sessions? And then the last one is, will you be on the right path to refer the patient to a colleague or senior doctor to continue if in the middle of your care you realize that the patient needs in-person assessment to aid the diagnosis? So any of you can take any of them. And we have just about 5 more minutes to go.
All right, thank you, Prof. Lawson. I think I'll start with the last question.
Yeah.
Yes, most definitely you'll be in the right path to refer this patient because per your assessment, you think that the patient needs an in-person care. So most definitely give a formal referral stating why you're referring the patient. Thank you.
Okay, so as Inoni said, it is one of the cardinal rules. If at any point your examination or your care requirements are such that the patient has to be seen in person. And I think we discussed it. You need to. Failure to do that will actually constitute a breach, and you find yourself in trouble.
Mhm.
Okay. So, Dr. Lawson, we don't have a lot of time. So maybe, I don't know which ones you want me to tackle first.
Or anyone you remember.
Okay.
Anyone you remember.
I think, okay.
Okay, go ahead. Go ahead.
No, go ahead.
Oh, if you remember something.
Okay,
just-
one. I think that remember one of them about the patient's privacy and
Yes,
confidentiality. Yes. I think that the patient has a responsibility to be in a private room or a private environment. They have also to protect their login details. That is their responsibility. They have to use a secure platform. That's their responsibility. They must confirm what the identity of their clinician. I think I can remember this for.
Okay. What about telemedicine being practiced at home?
So the issue here is this. Telemedicine, because of the way it is set up, you can practice anywhere. And it shouldn't be in a designated facility, so to speak. Because if somebody calls you on the phone, it's all part of telemedicine. Okay. Now, you can practice at home. However, at all times, make sure things are secure. That is the cardinal tip. Let me give you an example that usually happens when, let's say, you are consulting and a patient is at home. In the process, you as a doctor, we didn't discuss it, but these are some of the ethical dilemmas and other things that we may find ourselves in. You put chance on some activity that is happening in the home of the patient. Likewise, the patient will also chance on what is happening in your home. Now, assuming, let's say, for you, the doctor, you see some criminal activity in the background. The question is, do you report or not? The patient, also in the course of consulting you, you are in your home, see some criminal activity or potentially criminal activity happening in your home. Do they report or not? That it is better to be in a setup that actually ensures that privacy is ultimate and assured. But anyway, what you charge for some of these criminal activities, depending on the nature, by law, you as a professional, you are bound by law to report.
Okay. So in summary, you're saying that if he practices the telemedicine at home, he's okay.
It's okay,
All right.
provided he has a secure environment within the home.
Okay.
So that we don't have to see. The other problem with practicing at home is that in the process, others will also chance on what the patient is telling you. And that is a breach of the confidentiality, the data protection bit we're talking about, the privacy and all of those things. Because if a third person within your environs hears the consultation between, let's say, you and the president of the land, and he or she decides to lead certain things, it would have been your fault because your setting or your setup for the consultation was not right.
Okay.
Yes, so it is not just that home is bad, no, but the environment should be such that all the other ethical requirements are upheld.
Okay. Foxiga. I'll be grateful if you could enlighten me a little on how Foxiga contributes to weight loss. Weight loss, is there any direct relationship?
Yeah, there is a direct relationship by the mechanism of action. So in diabetes patients, the patient is expelling glucose. So the glucose transfers into calorie deficits. That is how it contributes to weight loss, basically.
All right. And then you answered this, but the question has come. Can Foxiga be given in heart failure alone without type 2 diabetes?
Yes, please.
All
It
right.
can be used in heart failure alone.
How much will it cost a patient monthly on Foxiga?
So that depends on the retail end. So it ranges around 600, 650.
Okay. 600 to 650. All right.
Yes, for a pack.
Okay. All right. So there are several. I personally had something about the Data Protection Act and how it dovetails into this whole telemedicine thing. Right from I give my data to a laboratory they move my data to an individual who maybe is a doctor, or a laboratory takes my data to another laboratory to work on the lab, comes back, goes to a doctor, moves from doctor to patient, and all those, that cycle where the information is exposed. Are there provisions within the Act that require that all these people, including doctors who want to do telemedicine, if you're going to do it privately, you're not doing it within a facility, the facility even has to register with the data. So could you just make a short comment on all this data protection?
Okay, so for data protection, we have a data protection commission. You are even required to actually be licensed once you handle, data. So just as Prof said, the business of you handling data may require certain further activities. So we should bear that in mind. 2, the data itself, sometimes also may sit with a third party beyond your position because of the nature of the platform you are using. That also brings some legal responsibilities on this third party. The vendor, the owners of that platform, they will also, depend on what they are doing, will be required to observe the data protection rules as well as go in for the registration. The third is that amongst us as health professionals, we are all bound by law to keep confidentiality as a very serious business. We are not mandated outside the work environment without the consent of that patient. So whether you are in the lab, whether you are in the ward, whether you're a nursing person at the X-ray, and we are all bound by it. And if there are breaches and it is determined that this was the source, beyond the overall responsibility that, let's say, a facility will be tagged with, you, the individual, you also have personal liabilities that have arisen out of your breaches. In fact, these confidentiality related matters, patient's record and all of it. In the US, for example, it got to a point, the sort of damages that people were getting from lawsuits were so high that some states were even compelled to put a ceiling. Yes, so it is something that everybody in the chain, remember at a point I discussed briefly, doctor-patient relationship, doctor-health professional relationship. These are all parts of the basket that goes into the provision of care under telemedicine and even regular practice. And we are all bound by law to preserve them when we breach them. And please, colleagues, let's also remember that, not in recent times, but generally the trend in the country is that a lot more of us are being taken on by way of lawsuits, complaints to MDC and what have you. Litigation is on the rise, and was one of the reasons why the new Insurance Act, the current one, prescribed that we should get professional indemnity. It is as a result of these things. If anybody tells you that malpractice-related matters are not on the rise, please go to your facilities and check. Go to Ghana Health Service, go to the teaching hospitals, and they will tell you the pile of cases they keep getting, on regular basis. It is not like before. I mean, some of us are privy to a lot of these things because of the other things we do in the legal realm, but we should all be very mindful. And it could be any of us. So let's, as much as possible, try and do the right things. And that is the essence of some of the discussions we're having today.
All right, thank you very much. I think we've had a very useful session this afternoon. We had 2 speakers. They spoke on different aspects of telemedicine, and we've learned a lot. We had a 3rd speaker who spoke to us. Our sponsor spoke about Forxiga. I would like to conclude saying that this topic has not been totally exhausted. I'm going to charge Softbox to take it further. I mean, we need to look at, for example, details of telemedicine prescribing. If you're going to prescribe using the telemedicine route, what are the options available? What's the best way to do it? Are you going to register with the pharmacy so that when your prescriptions go electronically to the pharmacy, they go and pick those kinds of arrangements? We need to find how we can fine tune that. Also, lab requesting, imaging requesting. How do we make sure that that system is not abused, because patient data is going to float all kinds of places. And sometimes imaging has personalized pictures of the individual, and that also needs to be looked at. And then finally, can we also look at software for telemedicine? Can we get maybe 2 or 3 that are very good, that we can get the vendor speak to the doctors about these software, the cost involved? Can we come in a group and purchase one? And how do we run it? What advantages and disadvantages of some of the systems? Ones that somebody has used that, we can recommend. I think we need to take that thing to the next level. We talked about it, we've heard about it. We've seen our mistakes after listening to the lawyer. So now we want to correct things. So we should be able to have a series of training programs to help us correct all these steps that we are not taking well. And then telemedicine will be done properly in our system. So from the organizers, I'm here. The next CPD program is on Thursday. So the flyers will be out. Please look out for it. Is this Thursday, right? Okay, so Thursday, look out for it and then join. So on behalf of the sponsors, the executive of SoftPog, I want to thank you for joining us. I think we had at some point 969 or something participants. It's been very well attended. Thank you all for coming, and we'll see you soon on Thursday. Thank you.